Hello, and thanks for coming today to our workshop for our Spalding Rehab's driving program and the interdisciplinary team. My name is Amy Donabedian. I'm an occupational therapist and certified driving rehabilitation specialist. We're joined today by many members of our team, doctors, nurses, case managers, all of the therapists, speech, occupational, physical, recreational therapists. So thanks for coming today. And I hope that today this will give us some more information about how a driving program works so that the needs of our patients can be met across all of the disciplines, and that everyone can understand their role in the process, and we can make sure that the patients are able to access the community safely. Learning objectives for today will include being able to describe two components of a comprehensive assessment following a medical event. Participants will be able to identify the roles of the occupational therapist and the interdisciplinary team members in the return to drive process, and be able to identify 3 screening domains that impact driver safety, as well as identifying a referral pathway for our patients that have goals of returning to drive or access to the community. So therefore, alternate means of transportation as well. The occupational therapist in general has a role. They're kind of first on as far as through a patient intake evaluation. Patient may be identifying that they were drivers, that they'd like to return to drive, and they're also being able to identify that there are issues either visually, physically, cognitively, and the occupational therapy generalist will then decide whether or not this is something that can be worked on through the OT basis, or maybe they need to move on and go see a CDRS for a full driving assessment. This is sort of a team discussion as well. More information to follow as we progress through today's workshop. The CDRS has specialized education, has completed formal education in the area of driver rehabilitation, as well as passed a national certification exam. In Massachusetts, there is a law that states that if a licensee has a medical condition that may affect their ability to drive, that they need to disclose that. We'll talk more about this process as we get into the doctor's role. There are 4 standards through the Registry of Motor Vehicles that are involved through medical affairs. First, involving vision. You have to have at least 20/40 vision to drive at night, 20/50 to 20/70 for daytime driving, and a minimum of 120 degrees of horizontal peripheral vision. There are loss of consciousness and seizure standards, as well as cardiovascular and respiratory standards, and also cognitive impairment standards. When is a driving evaluation appropriate? Well, it gives us a lot of information as far as whether or not a medical condition has impacted their ability to drive. So going through the whole process, we're identifying, has the stroke impaired their visual abilities or cognitive abilities or physical abilities, and determining whether or not what resources we need to make sure that we can recover so that they can get back to driving. We're determining whether or not this condition has resolved. We're going to give recommendations to the client, and we're also going to be able to provide the doctor with more information as far as their ability to clear the patient. So we want to make sure that we're giving the physician as much information as we can regarding their condition. A pre-drive assessment here at Spalding is 2 hours. We're looking at doing a thorough patient interview as far as their driving history. We're also looking at cognition, vision, perception, visual processing speed, brake reaction time, basic understanding of the rules of the road. Once this is completed, the recommendation may be to move on to an on-road assessment, either with or without adaptive equipment. We may be sending them out to see an ophthalmologist or another neuro-ophthalmologist or any kind of eye doctor who may be able to give us more information about whether or not there needs to be a more thorough visual exam. We do a screening. We might need more specific information about the exact degrees of horizontal peripheral vision. So that form might be what we need to have completed. We may ask the patient to continue with therapy, maybe from a physical aspect, their right or left lower extremity coordination, break reaction time, their balance, their endurance might not be ready for driving. So we may ask them to continue with therapy. Maybe from a visual aspect or cognitive aspect, we're looking at continued therapy before and on road because we want them to be successful. We may be actually telling them that we recommend that they retire from driving, which is a really difficult thing to do. We would be recommending alternate means of transportation, but also looking to our team members for support because this is just a one-time appointment and the patient may be dealing with some real independence loss. And how are we going to support that patient? So it's really important at that point that the doctor is aware of the situation, that case management's involved. We may be pulling in family members. So all members of the team really need to be on board with this decision and able to talk about it with the patient. And there are times where a patient could follow up with the registry as well. Following this, if they move on to the on-road assessment, we may be completing that. We're looking at that on-road assessment and trying to see if there's any links with what we've seen clinically. Are the impairment areas that we're seeing clinically repeating for the on-road, or are they not? Sometimes if a pre-drive assessment is completed and there are impairment areas, we can see that they're even more magnified on the on-road portion. So there are times though that we do the pre-drive, there are no issues, we do the on-road and there are no issues, and the recommendation would be to resume driving. We may recommend that they continue with lessons with a certified driving specialist or sometimes a local driving school if they do not have special needs. We may ask them to practice with a licensed driver. This is usually just for the particular patient that might be having some lack of confidence or anxiety surrounding getting back to driving, and they really just need a support person in the car. It wouldn't be for any level of skill. There are times that we need to discuss the results with a physician prior to making a decision, but that does not happen often. There are also times when we recommend that the patient move on to do a completed test with the registry as well. This would be a unique situation again, where the patient has a permit and they have to have it transitioned to a license. So they would then go to the registry for that. And again, after an on-road, we may recommend that they retire from driving if there were critical errors made. In that vehicle, we're looking for their ability to be in control of the vehicle, to follow motor vehicle law, and to have an awareness of their environment. If that's not happening, then the recommendation may be to retire from driving. As far as considerations for the whole team, from an occupational therapy perspective, the referral can usually moves along. But if occupational therapy is not involved, there can sometimes be a lack of communication for the patient. So we want to make sure that the team is aware and knows what the patient's long-term goals are, knows how the patient is getting to and from therapy. What other aspects of this patient are we not addressing? So it's really important that we're talking about how they're getting to and from places and making sure that OT should get involved if they do have goals for getting back to driving. From a medical perspective, looking at medications, how are the medications impacting the patient? Could we make changes? There is a nice app that looks at, it's called Roadwise RX, that looks at how medications can interact. We're also thinking about prosthetics. You might have a young traumatic injury that someone received a right lower extremity prosthetic and they feel fabulous with it, just like it's an extension of their actual leg, and feel like they can drive. It's actually considered a piece of adaptive equipment and they should be referred to a CDRS so that they can get the stipulation put on their license so that everything is legal for them to drive. Also, just understanding the progressive disease process and how that can impact a patient as they age and as the disease progresses. So it might be that we're establishing a baseline for a clinical and then watching them over the years. And if we're seeing any changes, then we would reestablish and reassess. At this point, I'd like to pause and have everyone view our case study. And then we're going to make some notes about the impairment areas that we're seeing and come back as a group to discuss. So I'll give you a few moments to go ahead and do that. And thank you all for joining today. And if you have any questions, please reach out.